Good evening, everybody. It's 8 o'clock, and welcome to today's episode of Marvelous Medicine, which is about healthcare in South Africa, the past, present, and what is hoped for the future. The speaker is Dr. Siva Marimuthu Pillay. I will just call him Shiva from now. He's a multi-skilled family physician with experience in general practice, general surgery, general practice obstetrics, general practice anesthesia in Kariega, South Africa. He's also one of the very few practicing fetal medicine specialists in the Eastern Cape province. Shiva Pillay did his MBBS from JIPMER Pondicherry and became a member of the faculty of general practice. He did his master's in family medicine and also diplomas in anesthesia, child health, and obstetrics. After that, he got himself certified as a fetal medicine specialist. Shiva Pillay was the superintendent, Department of Health, Eastern Cape, and under his stewardship, corruption and indiscipline was addressed, and the focus moved to primary health care, leading to improvement in health indicators. He was briefly a member of the parliament, and his dream is to provide universal health coverage to every citizen of South Africa. Shiva's hobbies are gardening, water feature landscaping, and he likes koi fish. Thank you, Shiva, for immediately agreeing to do this session and taking time off from work to join us today. Moderating the session will be Dr. Ranjit Baral. He's a senior consultant cardiologist at Gangalal National Heart Institute and Vayodhya Hospital and the chief of aviation medicine in Nepal. Dr. Ranjit Baral too did his MBBS from JIPMER Pondicherry. He went on to do his advanced clinical degree certificate from the Ministry of Health and doctorate in clinical cardiology from Japan. And he trained in aviation medicine at King's College, London. Dr. Ranjit Baral has several publications and presentations to his credit. He used to be a hockey, football, and tennis player, but it seems like he enjoys golf more. He's very active on social media and is a great role model for managing work-life balance. We'll hear a few words from you, Ranjit, before Shiva starts his presentation.
Thank you, Vidya. It's such a pleasure, to be on this podium today, meeting all old friends from our alma mater, and, where we all started. And now at this point where we are all giving back and going through Shiva's CV, my God, I think I could do another PhD. I mean, he has done so much, as you said, being not only member of parliament, but even in the medicine field, he has covered surgeries, obs, anesthesia. I think probably the only thing he has not done is neurosurgery and open heart surgery. Otherwise, everything he has covered, we are so proud of him. He was always a multifaceted character. And, down the years, hearing about him and now being right in front of us to tell us what all he has gone through in South Africa is a real pleasure. I hope there will be a larger audience to listen to him. And I don't want to basically what we did in JIPMER them days, but we were together through thick and thin, through ups and downs, whether it was football or whatever, we went through our guts, up and down, in JIPMER was a very, very hard institute where, the cream of the society from all over the world, especially from India, from different parts came over. And what we are today, we owe it to them. But, let's hear from Shiva before we interact again. Up to you, Shiva.
Okay, thanks, Ranjit. I'm just going to screen share a little bit. Share my screen. Open that. I hope the screen is visible to everybody. Is it visible?
Perfect.
Yeah, perfect. Very much.
Okay. First thing, thanks, Vidya. Thanks, Ranjit, for this opportunity to speak to you guys here today. And I hope it's a topic that's out of the mainstream of what we normally do, because it's about my country. But I'm also hoping that it'll have some significance in India for one reason. I can see that some of the things that we were planning to do and what was our vision is now happening in India, where the private sector is entrenching itself and is becoming the mainstream deliverer of healthcare, at the expense of the government. And then I see that universal health coverage may be compromised because really the private sector have no altruistic nature. They are for-profit organizations. And really, we have to watch what happens with them, because we really need to promote the public sector such that it can take care of all the citizens without, financial interest. So my topic is healthcare in South Africa, the past, the present, and the future. When I look back now and I started to write this presentation, and I had to think back, we have had 30 years of democracy. And when I start to think about what happened in the past, it is bloody unbelievable to believe that there was such an organized system of discrimination and exploitation of all human beings in South Africa, and that this was the international society and everybody allowed this to exist. When I started to look at the laws and everything, it was an entrenched system of slavery. And although apartheid is abolished now, its effects will linger on for a long time, and it will take years for us to overcome this painful legacy. Everything was kept separate. Even, for example, your sewage systems were separate. That's how crazy the system. Where they never saw black people, not many black people at all, because the working areas had black people, and they actually, in some of the places, if you went to, they were whiter than Europe. And even the whites had a false sense of security because they thought they were living in Europe because the way the system was built. As blacks, you had no rights whatsoever. And although slavery was abolished, this was a modern type of slavery. All they needed from black people was cheap labor. They were not interested in your well-being. They were not interested in your development. They were not interested in your health. You were just cheap labor, and you were actually modern slaves. And that's how the system was designed. Now, some may ask, how come we had educated people? Before apartheid in 1910, we were the Union of South Africa. And as a Union of South Africa, it was much more liberal, a little bit, and blacks were allowed to study. There were certain missionary hospitals and missionary colleges and things like that. But once apartheid got entrenched, it became crazy. And as it says, it was legal discrimination and an unjust system that was beyond comprehension. And this unjust system extended into the healthcare too. As such, if you look at it, there was the Land Act that made 91% of the land belong to whites. Then there was the Population Registration Act of 1950, which then put people into 4 categories. Either you were black, colored, Indian, or white. It was really stupid in 1950, because in 1950, many whites had already married blacks by that time. And they discriminately just put you in front of a chart. And they looked at you and they said, okay, no, you can become white, you can become black, you become colored. You had actually brothers and sisters that were separated. And that's when these guys wrote the thing called the blood knot. There was a play in South Africa during that time where 2 brothers, one was classified colored and the other was classified white because their mother was colored and the father was white. And they used to enact every weekend how each one behaved. And then the other guy said, are you sure this happens to you? And this guy says, no, but this happens to us as blacks. At the end, they became enemies, and they wanted to kill each other because they became white and black themselves. And his own brother, he was looked at his own brother as an enemy, because that's how stupid this Population Registration Act was. Group Areas Act means you could stay only in an area designated for you. That's why I said if you lived in a white area, it was whiter than Europe. You had pass laws where blacks were only allowed into the white area if they carried a pass. Separate Amenities Act meant that everything was separate, including the healthcare services. Everywhere you will get a sign which says, this service, this facility is only for whites, net blancas. And it was like that. It was considered immoral to have marriages between races. And there was a prohibition of them. Look at the word immoral. It was It was given even religious connotation that it is immoral for you to mix with another race. You had, Education Acts, the Bantu Education Act, whose only purpose was to make you a slave. Give you a little bit of education so you can understand the commands. That's it. There was a big thing about suppression of Communism Act. Communism was considered anti-Christ in South Africa. So if you want to swear somebody in South Africa, you have to say, you communist. Your communist is worse than swearing somebody, because if you were called a communist, you were like an antichrist, you were somebody. So if you talked about communism here, you would have been you would have been an untouchable. And then you banned organizations. You had stupid things like Indemnity Act, which says security police and law enforcement are indemnified from any prosecution if they take action against Black people. So they could beat you up, they could do whatever they want to you. Nothing is going to happen to them. Interestingly, even the Bible in Afrikaans got converted, and the Afrikaners gave themselves a covenant, just like the Jews were given a covenant to say that this is their promised land and all. The Afrikaners made South Africa their promised land to rule over Blacks. You can go and read that Afrikaner Bible today in the NGK Church. It's there. Now, this is a map of the homelands. All the colored areas, or what was called homelands, where Black people could stay, they had to come and work in the white areas. All the other areas were all belonging to white. So they just took over the land and they took over the country. So this year led to segregated health facilities, where the apartheid regime enforced racial segregation in hospitals, clinics, would separate and vastly unequal facilities for coloreds, Indians, Blacks, and whites. Now, Blacks were not just put all as Blacks. Indians were kept separately, coloreds were kept separately, and the Blacks were kept separately. So even among ourselves, there was discrimination, and people were not allowed to mix with one another. And Black South Africans got the worst brunt of all the discrimination, and they were treated really unfairly. They were underfunded, they were at overcrowded hospitals with limited resources and really, really poor infrastructure. The discrimination in the allocation of resources was despairing. And the whites, despite being only 15%, whites actually at that time were not even 8 to 10% of the population. They got 90% of the budget, and they had 90% of the hospitals and 90% of the clinics, while the Black people were totally underfunded. They were thrown into homelands. And in the homelands, there was nothing. You were left there to die. Basically, it was that bad. The best medical equipment, pharmaceuticals, and trained health professionals all were reserved for white patients. To the extent that you had 5 medical schools in South Africa, and they were all for whites. You had only 1 medical school in Natal Medical School at that time. And that was for non-whites, and that was for all the non-whites, whether you were Black, Indian, colored, it doesn't matter, but that was the only medical school. The idea was, if you could portray Blacks as not being educated, but you portray whites as educated, we had to go to them for services. A simple thing, like if you read Desmond Tutu's book, he said the first time he left the country and he was going to another African country and he saw a Black pilot going to fly the plane. He got panicked. He wanted to get off the plane because you don't believe that a Black man can fly a plane. Because that's how indoctrinated we became with this whole system. And it was a mind-boggling system of how it worked. There was geographic disparities in the systems where the geographical areas where whites lived got the best services, leaving rural and predominantly Black areas with minimal access to medical care. And then if you needed tertiary care, you had to travel long distances to reach the health facilities, and they'll have small amount of facilities for non-white patients, which is reserving like about 10% of the facilities for them in a facility just to make it clear. The issue about past laws and restricting movement was the way in which they kept the discrimination permanent. You were not allowed to come into the white area of South Africa unless you had a pass, and you could only get a pass if you were working in the area and you had to show you were working in the area. If you are not working in the area, you have to get back to your area, and that was it. They created hostels, and you were allowed to come to your hostel where you stayed, and you came to work, and that's all you were allowed to do. If you are found, you are not allowed to go into a white residential area or anything. And this, black patients were turned away from white areas and white hospitals, and they found to be, if they didn't have a proper pass, they couldn't. So now the only people that were given a pass were the domestic workers and the other workers who were allowed to go and work in that white area. So if you're a domestic worker and a black help, you had to have a pass, and they could stop you anytime and ask you, where's the pass? And if you don't have a pass, you were just thrown back to homeland, put on a paki and sent back. So this year led to an inferior quality of care for black South Africans, and you had less experience and less qualified medical personnel. First, you had a shortage of personnel because you didn't have black personnel qualifying. And then this was run basically by nurses and other things where you had substandard care with inadequate diagnosis, treatment, and follow-up for black. It was a system of neglect and abuse. Now, this history of public health neglect is long-standing because now it's not just health facilities, the whole public health services like sanitation, clean water, adequate housing, and facilities for black people did not exist. You are basically taken from South Africa, which is there, thrown in an homeland, and in the homeland you have to fend for yourself. And therefore, epidemics and pandemics were running rife in the homelands, and it was decimating people, but they didn't care because that was not the workforce. Another purpose of the past laws was this: they didn't have to pay money to people. If you worked in an area, after 3 years, they fire you. You go back to the homelands. But there was this pool of people left in the homelands who have 15, 20 years of experience because they got fired 3 or 4 times. But every time they were rehired, they started in the bottom of the rank again. So it was slave labor. You could never go up in the system, or like, say, I've got 15 years experience in this. You may have 20 years experience from working in an area, but your experience would have been broken up in between, and you started in the bottom rank all over again, although you had the full experience. And in this year, maternal and child health care was non-existent for black people. People like my mother and all, we had to deliver babies at home. To think that you can go to an hospital and deliver babies was unheard of. This policy is extended to Bantu education in healthcare training. The Bantu Education Act limited educational opportunities for black South Africans to the extent that they were just taught basic education. And those that came before the apartheid era, they came into the system and we were allowed to become professionals. Nurses were considered black help. Nurses are not considered professional. So in those days, you wrote what is called a JC certificate, which was grade 10. You could study wherever you want, and then when you came to grade 10, you had to write a JC certificate. And if you did a little bit well in the JC certificate, they might have went into nursing. But when you went into nursing, you became a nurse, but not a professional nurse. You're a professional black help. In 1994-95, when I came into power again, we had a lot of what is called staff nurses because they could not become professional nurses. They never wanted them to become professional nurses. They had 30, 40 years of experiences, but they were staff nurses, although they were much better than the professional nurses. Suddenly, in 1994, when the professional nurses came up and we allowed blacks to become professional nurses, the staff nurses that we had were much better than the professional nurses, but they could not become professional nurses because they didn't have a grade 12 certificate. A grade 12 is what's called metric in South Africa, because they just finished a junior certificate. And they were told, go and write metric again, go and write grade 12, then we can make you into a professional nurse, which was a stupid thing. In the end, that's why in 1994, we just had open exams for them and said, go and pass your bloody metric exam and become a professional nurse. Mental health was a crazy thing. They said, the brain of a black man is not sophisticated and developed enough to get complex mental diseases. So there was no disease like depression or other things for Black people. It can't exist. The brain was not sophisticated enough. We were taught in medical school, in the medical school in South Africa, Blacks don't get myocardial infarction because they can't suffer stress. What is stress? They don't know what is stress. This is in the medical books. There were forced removals and in the homelands, and this impacted badly on the system because when you were thrown into the homeland, let's say you were in the urban area and you were getting diabetic, hypertensive treatment, you went to the homeland, you got no facilities whatsoever, and you left to at the mercy of clinics that were understaffed, without resources, and left, and you were just left there and you just beg for a work again. And that's how they made cheap indentured laborers. So these violations were deep-rooted, based on racial inequalities and systemic neglect, and that's how the apartheid went. Some stupid examples that you can think of: blood was first classified by race instead of ABO. This had a bad effect because some white people who had, like, diseases where you needed blood repeatedly, if their white group couldn't give them blood, it's bad news. Because you can't give blood of another group to another person, because blood was classified according to race first. They were taught in medical school that Blacks, they have high tolerance for pain. So you mustn't give them analgesics and pain stuff too much because they can tolerate pain. And if they can't, they must be taught to, because they're going to suffer in their life. This was taught to us. Blacks were considered less sophisticated, as I said, psychiatrically, and so you couldn't treat for depression and stress and things like that. If you are a Black prisoner in South Africa at that time, you could be experimented upon, and they could do medical experiments on you, especially political prisoners. And I'll tell you about a doctor. There was a doctor called Wouter Basson, who was called Dr. Death. He was given a mandate: go and test nerve gases, go and test chemical warfare. Because the fear of Blacks, the fear of the white government at that time was that in case there is an uprising, there'll be a mass exodus of people from the back homelands into the urban areas. How do we quickly kill them? Can you develop poisonous gases that can keep these people and kill them before they come to us? And this guy was actually given a license to do that. And he was allowed to experiment on prisoners, especially political prisoners. Black doctors, you are not allowed to treat white patients. So if you're a doctor in South Africa at that time, if you're a white doctor, you had a separate entrance for your Black patients, and your white patients had a separate entrance. You treated your white patients first, and then you came and saw your Black patients. But Black doctors were not allowed to treat white patients. This was a crazy system, even if they're dying. In 1992, the mayor of East London, his daughter, were in an Easter weekend, got a ruptured appendix, and they were not allowed to treat. So what they had to do, they had to transfer her to a homeland in Ciskei, where I was the anesthetist, and I actually helped to treat her. But if I came into South Africa, I was not allowed to treat her. So they created this so-called homelands and TBVC states, Transkei, Ciskei, Bophuthatswana, and Venda, and they called them separate countries. So if a white had to be treated, they had to be moved to these places if there was nobody else. It is absolute absurdity. And yeah, I was good enough to treat the East London mayor's daughter, but I was not good enough to stay in East London or to enjoy any of the facilities in East London. So it's surprising. In 1993, 1994, although things changed, the white doctors still kept Black entrances for whites, Black entrances for Black patients, and white entrances for white patients. So there were people like me who then I went and sat in the whites only side, asking to be treated, because we had to break the system. And they were embarrassed because there were doctors who were working with me, and they didn't know what to do till about 1994, 1995. When the 1996, the Constitution got passed, then they had to all change. But this is how it was. As I said, nurses were considered Black help, but not professionals. You could sterilize a Black woman who came in for a Caesar or anything without her permission. it's allowed in South Africa. If you were black, you had no rights. There was a systematic process to limit black population explosion. And you could sterilize black women without their permission. If you take the first heart transplant, Hamilton Nicky did that, and that was a closely guarded secret. Nobody, it was only after about in the year 2000 that people came to know about Hamilton Nicky. No one even knew about it. What people do not know that Christian Barnard was charged in South Africa for allowing Hamilton Nicky, to come into the operating room when he had a white patient. It's only when he did the first transplant and everything, and because he was politically influential, they left it. So this is the kind of sign you'll see everywhere for white persons only. This is a sign you couldn't come to inside South Africa, that's white South Africa, unless you had a pass. This is a guy, Wouter Bosson, who was given like permission to go and experiment on blacks and see if they can be killed in case there was a mass exodus of people into the white areas. And this is how they considered blacks. When you just left South Africa towards the homelands, all the highways had this caution, beware of natives, as if natives were inhuman and you have to be careful of them when you're driving on the road. And that was the past. So in 1994, the country got liberated. We believed in a rainbow nation. The hope of Madiba came, and we really had new hope, and we believed in a better life for all. And with the constitution came our South African constitution is one of the best in the world, and it's guaranteed by a Bill of Rights. And the Bill of Rights gave you equality, human dignity, life, freedom of security and persons. You cannot be forced into forced labor. You cannot discriminate on race, gender, sex, pregnancy, marital status, ethnic, social origin, color, sexual orientation, age, disability. It is entrenched in our constitution now. And in this year, you have freedom of speech, freedom of movement, freedom of association, freedom to picket, and freedom of political rights. Now, to entrench this Bill of Rights, in normal places, you have a high court and a Supreme Court, and your Supreme Court is your court of appeal. But in South Africa, we have another court above the Supreme Court, which is called a constitutional court. And if you feel your constitutional rights are violated, you can just go straight to the constitutional court. We have Chapter 9 institutes. Chapter 9 institutes includes the Independent Electoral Commission, the Judiciary, the Public Protector, Human Rights Commission, Gender Equality Commission, a commission that will protect your cultural, religious, and linguistic identities. And these are separate institutes that are guaranteed in the Constitution, and they must be funded by Treasury separately and entrenched so that they are there. Our Department of Justice is called Department of Justice and Constitutional Development. So they must be seen to develop the Constitution. And ideally, the plan was to have a citizens advisory office in every district. And if any citizens felt his constitutional rights was being violated, can go and make a complaint there. And that will be fought for by the government. Now, it's good to have had these things. But what was the challenge that we faced in 1994? It was a huge challenge. Because as I said to you, they made separate countries. They had Transkei, Ciskei, Bophuthatswana, Venda, which were separate countries. In addition to this, they had separate Bantustans. And we had 4 provinces. So we had to unify 13 different departments of health, each with separate conditions of employment, each with separate salary structure, each with separate organograms, and we had to unify this into one unitary health system in South Africa. We then had budget constraints because a huge amount of money was borrowed to prop up the apartheid system. And we were sitting where 46% of our budget was to pay foreign debt. Where this unequal distribution of facilities and infrastructure, where previously advantaged whites had the cream of the facilities and the poor indigent whites had nothing, and there was an expectation for them. There was a disparity between rural versus urban. most professional services were in the private urban area. In 1992, in anticipation of change, the private sector was deliberately deregulated so people could join medical aids and not depend on the state service. And at that time, you could buy private healthcare and you deregulated the medical aid and it built up this private sector system. At the same time, there was uncertainty. We had flight of capital and human resources where there was a fear of a black government. And then the worst thing happened was that to make the change happen fast, we agreed to certain sunset clauses. The sunset clauses, Madiba had this vision where we'll have a government of national unity and all people will participate. But the whites and others, they decided, no, it must be a winner takes all system and people must vote and you'll vote for a political party. Then they agreed they wanted 9 provinces with each of the province having their own separate health system and health being a provincial function. Then we said all those that were employed by the previous governments, if they had to be removed, they had to pay voluntary severance package, which would have costed the government a huge amount of money. Then the pension funds and all the funds that were existing there for previous employed people had to be ring-fenced and kept separated privately. And this generated ownership for whites. And we said property rights and ownership rights will not be tampered with. So you had this huge ability for whites to enjoy all the benefits that they enjoyed before while being in a democratic process and hoping that the changes will take. So it was those uncertainty, insecurity. And during this time, to stabilize the situation, Mandela said, if we put something as an ANC health policy, the whole world will come against us and they will say we are bringing, and as I said to you, that time, if we talked about socialism or communism, they said we'll be bringing communism in South Africa, and communism was considered a swear word. So in his wisdom, Madiba then decided to say, let's invite WHO and UNICEF, and let's draw up a national health plan for South Africa. And this was the national health plan that was brought up at that time. And it was drawn up in 1994. Me and Thabo, we were part of drawing up that health plan. And that's the health plan became. So then we put it to the people, this is not a health plan that we as communists are drawing up. This is a WHO health plan and it's equitable services for everybody. Can we all agree to this? But as I said, during that time, we had an unequal system. The private sector in 1994 was spending 67 billion on 15% of the population. And the government was spending 60 billion on 85% of the population. This is totally unjust. Even up to now, it is unchanged. In 2023, I'm supposed to say, sorry, not 2003, 2023. Let me just go up there. That is supposed to be 2023. We spent 200 billion now in the private sector and 275 billion in the public sector. But the public sector caters for 85% and the private sector caters for 15%. This is a totally unequal system. This leads to inequitable human resources because everybody follows the money. And you got now a parallel system of duplication. Now, if you come into a town, if we have one MRI scan, every 5 private hospitals around there will have their own MRI scan. You have duplication of services and raising of costs. Now, the private sector is totally curative in its approach. It is not promotive or primary healthcare orientated. And you just went there and you got cured. But in terms of preventative and promotive care, there is nothing in it. And if the state does not do that, we are in trouble. So the interest of 85% of the population must take precedent over that of the 15, and therefore you have to get reform. But if you think that the private sector, which was, I agree, is world class, it's in fact better than Europe and everything, it was not without its problems. Yeah, all employed people and members, they contribute to a medical scheme. At that time, this medical scheme was unregulated. It was an insurance company. And they paid providers. And this was a Bermuda Triangle where money just got lost because the members paid money to the scheme and they felt they could go to the provider anytime. the providers also didn't have any responsibilities because every time they saw a client, they got paid. It was a fee-for-service system. So the providers and the doctors and all the providers here, they said, let's milk this as fast as we can. And therefore, by 7 months or 8 months in a year, benefits were getting exhausted. The schemes and administrators were just handling money. And there was no co-responsibility, there was no cooperation, and it was a system of mistrust. And schemes and administrators were for-profit organizations, they were not mutual funds. And then there were a whole lot of people dipping into this, pulling out money, including the service providers, who were then not allowed to say, you will limit your fees to this for this procedure or anything, because health was commodified. And I'll explain that just now. So therefore, health reform was inevitable due to the non-sustainability of the 1994 system and the fact that 85% of the people were depending on the state. And therefore, there was need for convergence and optimal utilization of all the resources for all of the population. And that's when the whole idea of universal health coverage was proposed. Unfortunately, universal health coverage in South Africa is called NHI, because it's called NHI because of the way we structured it. At one time, we were saying, should we go like the NHS system in the UK, where we just pay people and make them salaried employees and provide a service and it becomes the NHS? But in South Africa, it was decided that it will be purchaser payer split, where we will have a fund and people can purchase from that fund. And that is why it was called NHI. But the principle was that every citizen shall have access to equitable quality health care at the time of the need, irrespective of their financial circumstances. And each shall pay according to their ability. So if you earned more, you would have paid more, but you will receive equitable health care, according to your need, not according to how much you could pay. Surprise if I have to tell you that the NHI or the NHS started in South Africa. The first document on the NHS came back in 1944 with a guy called Henry Gluckman in South Africa. And he developed this plan and he talked about universal coverage. This plan in 1946, 1947 was taken to the UK and made NHS. It is a white South African, Henry Gluckman, that made the NHS system in the UK. People don't know this. And he left a legacy behind and we have to follow it. And therefore, in 1994, we came to saying, listen, this NHS or universal health coverage is not our idea as Madiba or WHO. It is Henry Gluckman's idea from 1942 to 1944. And we are saying that all of South Africa's healthcare resources must be used optimally for all of its citizens. Let's end this debate of what we're going to do and how we're going to do it. There was a host of transformation plans, including last year when we passed the NHI bill. But the most important transformation plan here was the Mafeking resolution, where we said, listen, we are vacillating too much about implementation. Remember, when we came out with the universal health coverage, there was a huge fight back from the private sector because they didn't want to be nationalized. And I mean, in 1995, we came back with a fantastic deal plan. It was just didn't see the light of day. Therefore, in 1997, the Mafeking resolution came up and said, listen, draw up a roadmap and bring this NHI or universal health coverage. Otherwise, it's not going to happen. And from then, 1997, the Taylor Commission was started. And it did fantastic amount of work. Thabo and I worked in that commission. I sat in the Taylor Commission. I was a member of the Taylor Commission. And we drew up the roadmap. And we said, we will have an NHI committee which will draw it. But we failed to recognize that we faced a lot of shortcomings because of one reason, there were too many private hospitals. There were limited, we gave limited private practice where private doctors working for the state, while collecting money for the state, were allowed to do private practice. And Anna said we put health on part of the general agreement for trade and services. So health became a commodity that could be bought. And so there were other strategic challenges that we didn't recognize, and that caused delay in implementation. But if I had to show you, we had a fantastic plan. And this is the Taylor Commission's proposal. We said, first, let's prepare the public sector with a proper budget system and budget properly for what we're going to do. Bring about public sector health systems that will prepare yourself for universal coverage. Consolidate the medical scheme reforms such that the medical schemes in the private sector get regulated. That is what is needed in India, by the way, now. If you don't regulate the private sector, you're going to have a serious problem in the future, like what we have now. Develop an integrated subsidy system and implement measures to contain the private sector such that you get universal coverage. You bring about risk equalization, so you pool your resources, you get an adjusted tax subsidy based on need rather than what geographical and other distribution. Get a state-sponsored medical aid to precipitate this and make it happen. Get statutory mandates where large employers must be forced to employ people. High-income earners must belong to schemes. And then you have a voluntary contribution where you have what is called social health insurance started. Set up a central equity fund, and then you'll get to universal health coverage. So in that system that existed in the past, if you paid your general taxes and your budget, you could go to the public hospitals and the public system. But if you had a medical scheme, it was a risk-rated thing where if you were older, you paid more. If you had diseases, you paid more. And it was like an insurance. And you got benefits, and if your benefits finished, you had to fall to the public sector. So then the Medical Schemes Act was supposed to put in, and it said it will community rate. Everybody will pay a rate based on either the income level or the employer status. It shall have open enrollment. You can't cherry pick young people. You can't exclude sick people. And if you dumped people to the state, you'll have to pay that money to the state because you'll have what is called a DSP arrangement, designated service provider arrangement. Eventually, all government employees shall belong to a state-sponsored scheme, and they shall use the private sector such that the public sector, such that the public sector will have differentiated amenities and be able to raise money, and this money will be able to upgrade its facilities. If you wanted to use the private facilities, you would have to pay a co-payment and manage further. Then we wanted to say, set up a system of norms and standards. So you say, what should be the standard of care so that everybody can get what is guaranteed in the Bill of Rights as a standard of care that people can come. So Madiba said in 1994, we'll start that children under 6 and pregnant mothers must get free health care. So that was the first thing that we did. But since then, we didn't move any further. Then we said, when you join a medical scheme, put all that money and put it into a central equity fund, where then this fund will then redistribute monies that were collected based on either age and illness profile. So although you may have 160 schemes, you will get, according to the age and sickness profile, monies, and you have to manage that monies and manage how you do this. And they had a funny thing, is you got a tax subsidy. So if you joined a medical aid, the amount you paid for your medical aid became a tax subsidy. So eventually, people are being subsidized 25 to 30% of their contributions. And if you look at the tax subsidy was 6 times what we were paying for an indigent patient. So it created an inequitable system. So you have to revise the tax subsidy into a central equity fund, which could be then even distributed to the indigent people. And the central equity fund will then have a public sector, which is a social health insurance fund, which will also join the medical scheme, and it will become a central equity fund. And then this central equity fund will become your national health insurance, which will then pay for health services which people could buy from any persons that they wanted throughout the country. And that's how we hope to bring about it. So the system was that you'll have a government, you'll have people who are employed, you'll have a basket of service, which was the first pillar, and second pillar, which was primary healthcare and secondary healthcare and tertiary care. But discretionary benefits like dentures and other nice to haves were put as third pillar. And that will not be part of the system, but part of the system will be the first and second pillar transfers, What would then happen is that you'll have a national health fund, which will distribute money to the different provinces based on funds that they collected from earmark tax. So it means that if you earned more, you would have had to pay more. If you earned less, you would have paid less earmark tax to an NHI fund. And the earmark tax will go to a central equity fund, and it will be distributed to the provinces to pay for these services, where each shall pay according to their ability, but access healthcare according to their need. And then for those that do not have a medical aid, the government will make the first pillar transfer from general taxes. And that's how you, and the medical aids could then provide supplementary healthcare. And if you didn't want to use these services, you wanted to do buy-up, you could pay extra and join a medical aid. And this is the timeline, and we were supposed to introduce all of this by 2005, but because the plan died, and this was a trajectory of what we are supposed to do in the whole thing and make it happen by 2005, but our plan died here. And it died there because of one reason: huge pushback, huge pushback. Suddenly the pharmaceutical companies, because the pharmaceutical companies were not interested in the public care, because 90% of the budget was in the private care. So they were not worried what are you going to do for the public. They wanted this private care to continue. So the private sector came back and they spent huge amount of money doing campaigns, putting adverts in papers, taking the government to court. The National Health Act was stuck in court from 1996 to 2005. The Medical Scheme Act was stuck in court from 1999 to 2002. So the private sector just hit a huge pushback, and it was impossible for us to move forward from there. We then got hit with other problems. In 2000 to 2002, we were ravaged by HIV and AIDS. And it hit us the worst. Sub-Saharan Africa and South Africa was hit with AIDS to unbelievable proportion. Can you imagine if I tell you that 26% of our population were infected? And at that point in time, our president was an AIDS denialist, refusing to start ARVs. Our experienced workforce got decimated. Our economy crashed. Suddenly, you had secondary TB pandemics, secondary emergence of other infectious diseases that people were able to manage, but with HIV and AIDS, they just started to die. If I had to tell you what it was like in 2000, we were having an average of about 50 to 100 funerals a day in a small city like Utenek. People were just dying. Now, with that, we gave a quadruple burden of disease. Because of 1994, the abolition of migratory labor and everything, we had a population boom. And mother and child health services were not able to cope. And we were having huge maternal and child health morbidity and mortality. Now, because of the HIV and AIDS problems, people became despondent because we had what was called a nothing to lose syndrome. When a person got HIV, he knew he was going to die in 2 years. So those persons, they were not bothered. They would go on violent sprees. They would go on criminal sprees. The rate of trauma and killing was just unbelievable. We have another pandemic in South Africa, which is called motor vehicle accidents. If I had to tell you that in an Easter weekend, from the Friday to the Monday, from Good Friday to Easter Monday, on an average, more than 300 people die in our South African roads, and more than 30,000 people get injured. And we are not able to stem this motor vehicle accident. And that is also contributing. The private sector also started to take strain, and about 16 or 17 schemes at that time tanked and went bankrupt. Budget cuts became compounding. Let me explain budget cuts. Here you had a privileged white hospital, and it had all the facilities and everything, and the other side you had nothing. So you had to actually, to bring services to the other side, you had to bring budget cuts to this side that was privileged. and they started to collapse what was existing. But the budget that you gave to the other side was not enough to maintain a service. So in the end, instead of at least having one thing working, both started to collapse. And the effect of the budget cuts started to collapse the whole system. The population distribution in South Africa, where we had now all the active, which was sexually active, which is the economically active people dying of HIV, and we just had a huge child population, and we had child-headed households. 20% of the households in South Africa, the adults had died, and the children now were heading households because of HIV and AIDS. At this time, we had multiple leadership changes at national and provincial level, and we had therefore patchy and uncoordination implementation of transformation plans. Although we had a transformation plan, it was not going anywhere. And there was an emerging trend that came back where we were a revolutionary organization in 1994. All of us who led the liberation movement, we were interested in changing lives. Suddenly they became politicized. And then we got what we call politicians started to take over. And to give you an example, in 1994, every provincial minister of health came from the ANC health desk. By 1994 and 1996, only politicians became ministers of health. All the health people were out. And the whole system became politicized, and revolutionaries and health activists got lost. People like Tabo and myself were thrown on the sidelines. However, in 2005, after the 58th World Health Assembly on universal health coverage, suddenly South Africa became a point of where there was convergence. WHO felt that South Africa was the most advanced African country, and if they can bring universal health coverage in South Africa, it will trickle and it will spread into the other areas of Africa. So therefore, in 2005, we got a huge push. In 2007, we got a funding of people coming to South Africa to help us to develop a health plan. And at that time, they campaigned because we knew that in 2007, we were going to get a 10% windfall in our budget, because in 2007, our foreign debt was going to be paid up, and by Madiba's negotiations to decrease the interest rates and everything, and we could use some of that money to bring in universal health coverage. So in anticipation of that, suddenly there was a renewed vigor in this time. And then, as I said, the Medical Schemes Act got passed. I was part of the team. I set up the Medical Schemes Council. I was part of the team that was in the Council for Medical Schemes. And at that point in time, we said, let's revive and rekindle the interest in the Taylor Commission and make it happen again. And the WHO has a team called Choice. Choice is choice of interventions that are cost effective, that can bring about social health insurance and universal health coverage. Believe it or not, this group was in South Africa for about 6 months. It was an imminent group of people, and they developed the plans. And we were all ready to go, and we were said, come 2007, when we get our budget windfall, we're going to implement NHI. Unfortunately, bad news. When 2007 came and the money came, the political parties started to panic that it will not get re-elected. And instead of spending the money on health, they decided to do two things. Let's steal as much money as possible. So they went and bought arms procurement. Arms procurement is notorious for kickbacks. So politicians got huge kickbacks from arms procurement, which made people millionaires. The other thing that happened was that let's give grants to people. They started to give child support grant, indigent grant. In fact, from 2 grants, we went to 9 grants, hoping this is like in India, where I'll give you a television set to vote for the ruling party, you know. So they handed out these grants to indigent people, such that in South Africa today, 46% of our population is dependent on these social grants. And we didn't spend the money on health. it became worse. If you look what happened here, the budgetary allocation actually decreased because the policy shift took place. Instead of being a socialist government, we decided to go into gear. Gear means that we will invest in infrastructure, we'll invest in business, we'll invest in capital business. And capital business will employ more people. More people will get rich and join the private health sector. And then that will cause a trickle down effect of the economy, and where you get a trickle down effect of benefits, and the population will benefit from this. The trickle down became a drought, and nothing trickled down. And instead of trickling down, they cut the budgets from 11.2% to 5.8 to 4.5. And these budget cuts just decimated the Department of Health. And as I said, at that time, whoever became a Minister of Health became a fall person, because you had paralysis analysis, they couldn't start anything, uncoordinated implementation, and you had poor stewardship. Despite everything that was happening, by 2008, the government still lacked a documented vision for a sequence reform roadmap with timeframes for implementation. And that's how the whole process got lost in translation. So although NHI is a noble goal, if you go to anybody in South Africa, 90% of the people now, they'll say to you, we want NHI. You go to anybody, because you must not mistake the fact that we couldn't implement, that people did not want this. 90% of the people want universal health coverage. It's an ideal that everybody wants. The government is failing to implement it. And NHI is a long-term process with goals that need consistent leadership and champions with institutional memory for successful implementation. And unfortunately, that institutional memory is lost. Came to 2009 to the 2020, we had the Zuma years, and this was the kleptomaniacs years. All government departments got captured. They were just there to line pockets of politicians. I was in Parliament in 2009, and Jacob Zuma, when he became president, he called me and he said, Fanagit, please come and join me. And I thought, okay. And he said, your nemesis, Thabo Mbeki, has gone. And you wanted to bring ARVs at that time, but now you can come and do whatever you want. And I joined Parliament for 5 months. I got the most powerful portfolio. I was the chair of the public enterprises, means all the public enterprises, Eskom, Dinel, Telkom, and all the public entities were under my control at that time. But it was a stupid system for one simple reason. This guy used to come in the caucus and says, I've brought Lucky Montana, and you must make sure he gets employed in Transnet. And I was the only guy, and a few of us, we used to oppose this and say, President, you can't do that. The state is separate, the political party is separate, and you have to do things according to government. He didn't listen to anything. So in 5 months, I left the Parliament. And then that's when state capture started. And then public institutions like the Treasury, SARS, the National Prosecuting Authority, all state-owned enterprises got captured. We had a guy from India and family from India, Guptas, who came here. And they took over all these companies and they managed it. Suddenly, the Council for Medical Schemes, which we established in 2000 and was going, suddenly became dysfunctional after this. And we were supposed to use this medical schemes to develop administration system, develop a basket of benefits, do cost benefit analysis, do universality of memberships, to get electronic clinical record, to do all these systems that we are supposed to do for universal health coverage. Nothing. All the conditional grants that we gave to prepare for NHI got wasted in other things. And it didn't go the way it was supposed to go. Thabo Sibeko was sitting here and listening. He was given money to do hospital revitalization for differentiated amenities, to put in patients into the public hospital so that you generate money. Never got implemented, and it died off. And so we then said, we're losing professionals. Let's give an health professionals development grant. And we gave an health professionals development grant, and we put people into medical schools and other things like that. Unfortunately, when we came back to employ them, the government had no money. We set up our Office of Health Standards and Compliance to say, let's accredit facilities, then we can actually make sure that which facilities will be ready for universal health coverages. It also died off in its whole process. Where we said, let's make a government employees medical scheme, and all politicians and parliamentarians and all must belong to a government scheme that must use the public facilities, and if they want to use the private facilities, they must buy up. Never happened. They're all using the private facilities. So in effect, now you've got a world-class private healthcare in South Africa that is better than most European countries and better than the first world countries. It provides high quality care in modern facilities with advanced technology. There are no waiting periods because you get a fee for service. If you want to do a tonsillectomy, you go to an ENT surgeon, he will do it because you'll get paid immediately. So you got over-servicing rather than under-servicing. However, the system is unaffordable to the majority of the population. Only 15% of the population can afford it. And that too, it's propped up by a subsidy system. But the recent promulgation of the new NHI now has caused migration of professionals again. If I had to tell you that in Canada, Australia, New Zealand, and UK, 75% of our doctors left the country to those places. You can go to Canada enclaves in the rural Canadian systems. You'll find them speaking Afrikaans, South African language, because they're all South Africans in the outback hospitals. Certain fields like obstetrics and neurology, etc., because of medical insurance costs, they're becoming almost difficult to obtain. In my town now in Utne, I'm the only person providing obstetric care in a 150-kilometer radius. It is crazy. So, and most private facilities are in the urban area. Yes, we want to say apartheid went out, and legally apartheid has been delegislated, and we have Bill of Rights. And we have improved living conditions for millions of people where we brought water, electricity, housing, better employment conditions, minimum wage, and we gave grants. But the backlog is huge. Where we had 5 medical schools, which was then, they're all open to blacks now. And we have had 3 more medical schools with 1 more in the pipeline. But we are still saying at the present moment, the backlog is too much. And now we are being ravaged by unemployment, crime, violence, gender-based violence, and other things. And we still have a dual system. It's still inequitable. And we have inequitable resource allocation. And we have a problem. We have a problem of legacy where we have still now 9 provinces.
9 provinces, and all 9 provinces are collapsing.
We have 8 of the 9
provinces that are technically bankrupt and owing millions in debts.
We have medical negligence cases and rising every day, and the government is unable to pay. Worse now, the ruling party has lost its majority, and we don't know where we're going from here. Public hospitals are without stocks, drugs, supplies. There is a moratorium, and although 80% of our graduate doctors who graduated last year could not be employed, despite having huge staff shortages, politically we are at a knife edge and we are at the risk of civil disobedience. It's against this background that the ANC, as an election ploy, is my opinion, proposed the passing of NHI bill because they knew that 90% of the population wants NHI. But the bill they passed is half-baked and it does not address the fundamental problems. And although we passed this bill and we got a euphoria, we are uncertain where we're going with this thing. And although we passed this bill now, we now have a government of national unity and we don't know how they're going to take this. But you cannot implement NHI in a vacuum. The current structure has to be reformed. And this cannot be done by legislation. It has to be done by implementation of fundamentals of improving the system. Without doing that groundwork and building a platform and a foundation, the NHI implementation will just die. We 100% support the idea that citizens should receive appropriate care according to the need at the time of their need, irrespective of the financial circumstances. And we support this 100%, but we don't believe the current bill will be opposing this. Now, there are millions of other people who are opposing the bill. They're opposing the bill for their vested interest to maintain the private sector. I am opposing the bill because I'm saying it's not attending the fundamental system. And they mistake me for opposing NHI. I'm not opposing NHI, and I'm not opposing universal coverage. It's my dream that we have universal coverage for all the people. But right now we are at crossroads with uncertainty in policy. We have an act that is flawed and open to challenge. We think is going to be challenged in court. We have a government of national unity, which is now we have got different political parties or different ideology. We don't know whether they'll be able to work together. Worse, we have got counter-revolutionary forces like EFF and the MK party, who are radical people that they don't care if they burn the country, but they are just interested in lining their pockets. And we brought back a new Minister of Health. And the good part is that he's acknowledging that we have challenges, and he's promising to hold hearings, to listen to concerns. But at the present moment, we have to just say and look at it. I want to end here by saying, if you wanted to get universal health coverage, we have to get the balance right between equity, efficiency, and where we put the fulcrum. And I'm saying you can only increase efficiency by decreasing costs, but you have to increase the quality of care. That's how you bring in efficiency. If you decrease quality of care, you can't increase efficiency. So therefore, to provide equitable and universal care at the highest possible cost, at the highest possible quality at the least possible cost. And that's the vision that we want to move forward. And Ranjit, I want to end there. I hope I covered what people want to say. Thanks.
Thank you, Siva, for this. Yeah, I mean, it is a very, very comprehensive, very, it's mind-boggling. I can imagine, in fact, I can't imagine, not imagine for you to be involved not only in medical part, but also all the political aspect. And, South Africa is, I think, a very, very complex nation with its apartheid. You had to deal with that and the transition period. And unfortunately, with all the, corruption which has been ingrained. And for you to, be part of it and try to tackle it, hats off to you from the JIPMER side, what you're trying to do. I know it's not easy. In Nepal, basically we're a very small country, so it's much, easier to handle things. When I came to JIPMER in 1978, there were no medical colleges in Nepal. Now there are more than 20. And, at that time, all our medical students used to go to the Soviet Union. The Soviet Union had their own agenda, 7 years course, 2 years language, and, you finish off and, we don't care, whether you're a good or a bad doctor. And the second was India and then Pakistan. Some of the people used to go. Now, most of the, our students, either they're, 20 medical colleges, they are here, but the number one foreign country they go to is they go to Bangladesh, and also secondly, India, and some also to China. The issue, like you said, so many export migration of the doctors, we are having those issues, because none of the qualified and, good doctors wants to practice in the rural areas. They're all concentrated either in the capital. And our doctors are also doing practices not only abroad in, US or UK, but also in neighboring countries like, Maldives and all that. We have quite a few students coming from Maldives, Bhutan, and all those places. But when I came back from Japan, there was no angiography in cardiac field, we were, everything we used to either, if people had money, they used to go to Singapore or go to Thailand or go to India. But now, things have advanced here quite a bit, not only in the private sector, but also in the government sector. We are doing all the, not only angiographies, but, angioplasties, bypass, TAVR, and, and I'm very much part of the cardiac society here. And, we have world-class, eye surgeons, and, things are getting good. But also, as you said, corruption is, part of the society wherever you go in the world. We have to be part of it. In fact, from Japan, I had offers to go to the US and, to Switzerland, but my wife just wanted to come back to Nepal. And I knew if I joined the government sector, the politics is going to eat up my brains. So she joined the, the government hospital. I never joined, I joined private, but I also joined the National Heart Institute as a volunteer, but I worked, past 27 years without salary. So like, Shiva, coming to some of your data here, like, whatever, like, ups and downs and all the difficulties you faced in South Africa, I see very good data here, like, let me just bring two data here, like infant mortality rate and life expectancy. I mean, coming from 18% to like 8.5% to 1%. In fact, in Nepal, like infant mortality rate in 1990 was like 8%. In 2015 is 3.4%. So you're doing much better there. But the thing that intrigues me is the life expectancy, which you've written, 51.5 to 50, more than 55. When I was born in Nepal in 1960, the life expectancy in Nepal was, 40 years. Can you imagine? And 1980, it went to 48. 2000, it went to 60. 2021, it was 72. And then 2024, it dipped to 70, probably due to our massive earthquake and the COVID. I don't know. But still, I expected, I think, South Africa to have a, a higher life expectancy than just more than, 55. We are still down in infant mortality rate compared to South Africa. That is one thing maybe you can, clarify there. But overall, what you've done in South Africa with this thing, like, only you could have done it. Like, trying to handle all this different kind of, I can understand, like all this, pharmaceutical companies, how they try to push, how they try to buy stuff, and like, but we here in Nepal, what we do here, like at least in the cardiac field, is if you're not going to implement for the poor sector in the government this thing, like, we're not going to, like buy your stuff. So we give them a very stiff this thing, So it's like a, give and take kind of thing. So as a result, like, I think like, as I said again, like, we're a very small scale, Nepal. So it's much easier to, handle things when certain group of people try to do something, let's do something for the country. Then for you, like trying to handle all those kind of things, like, I think I would have needed a psychiatric, expertise. Okay, so up to you. Can you elucidate something more?
Well, there's
some question
in the chat box.
in the chat box.
Let me just try to answer.
Let me just try to answer that.
The first question is that, is the Black population homogeneous? One of the things that the ANC did when it came back, he said, we are a non-racial, non-sexist liberation movement in which all people are equal. And when we wrote the Freedom Charter, South Africa shall belong to all who live in it, both black and white. And the liberation movement managed to make people into an homogeneous sect of people. But we have many different sects. We have Ngunis, we have Xhosas, we have Zulus. Now tribalism is being brought back again in the latest elections, where Jacob Zuma, after he lost power, is bringing back tribalism and Zulu, and he wants to bring back kingdoms again and everything again. And it's really a problem, and we have to fight that to the nail because we killed it. And if we allow it to take root again, we're going to be in serious problems. So that's one of the things that I wanted to say. The second thing that I wanted to say, you talked about indices there, Ranjit. Let me explain about the indices. That was when I went into the Department of Health, and Thabo was my Deputy Director General there at that time. We were mad guys, because irrespective of what the politicians thought, or even irrespective of what they wanted to do, we went on with our plan. And that's how we could bring about the indices. We shifted resources where we were spending 72% of our resources in hospitals and not primary health care. I shifted 58% of the budget from that to primary health care, and I was able to bring the change. Can I just say to you, 70% of what I did has been reversed after I left the department. And we were, you will ask Thabo, and he will tell you, we worked day and night. We were like will pitch up unannounced at any hospital to ask, why is this like this? Why is this not happening? And I used to fire people on the spot. And I said, I'm not worried about Labor Relation Act and all. I'll sort out the rest of the things. If you don't take care of the people, you got no place in our department. And if you were corrupt, I did that. So I was like a mad guy who did that during my time. And it was able to do it. But you will not get another person like that because they are scared of their jobs. I didn't care if I lost my job or anything. I was one of the few guys who took my minister to court. I went to court saying my minister is not doing what he's supposed to do. And of course, I lost. They don't renew your contract. You get my point. So I didn't mind. I said, I will do whatever I can within my contract. When my contract expired, they thought I will drop the case against the minister. I continued the case against the minister. He was declared unfit to hold public office for 5 years, or unless he gets a degree in public health. So I'm the only guy who took a minister to court. But that's because we were mad and we did that. But not everybody can do that. So, and that's why we've got indices that are good, but you have to look at it. The next thing that we were asked is that, many parts of the world, this for political hierarchy, we're not batting for a nationalized health system. Now, we are saying, okay, a national health system as like NHS has got its disadvantages also, because NHS, you all work for a government, you get the same pay. That's why we said, let's get a compromise to get to what is called a NHI, National Health Insurance. You'll get a basket of service and say, this is the fee that will pay for this basket of service for this community based on norms and standards. Whoever can provide it, whether you are in the private sector or the public sector, you can provide it. So we didn't advocate for nationalization of services. But however, when 80% of the people are dependent on the state sector, that has to be a priority. That's why we have to look at that. But you are saying the private sector can exist, but it will provide the services and like that. And that's why we put what is called a purchaser-provider split. And in building what we called it, we didn't call it NHS, and we called it NHI. Therefore, I know it's harakiri to say don't have private sector because they will execute you. But we said, how do we manage both and take it to a system that takes us forward? I don't know if there's any other questions. I must try to find the questions. We also just wanted to say the honeymoon period with Mandela is now gone a little bit because, we could before this say, we had the Mandela years and we have the Rainbow Nation and all, but now the honeymoon period is gone and we have to bet on our own. I know, Thabo, would you want to add anything? You can please do.
Just a correction, Shiva. I think you missed it. There was a confusion that you meant Mandela was a denialist. That's one of the notes I saw here. No. The person who struggled with the concept was Thabo Mbeki, not Mandela. Mandela was for it. I thought I should correct that. To me, just to summarize, the main part of the story is to say, if you are going through a reformation of a country or a revolution of the country, there needs to be consistency throughout the stages of the revolution. We had a good plan because we're activists that time. And then the issue of politicization became politicians. For example, most of our ministers in the provinces now are not even health workers. So actually they don't have a clue. So I think as a lesson for other countries, I think it's important that there must be consistent. When a new minister comes or a new leader comes, he must have a handover from the previous leader and continue, unless it's a new party completely. Because we as the ANC, we don't have an excuse. It was our own people who didn't take the bet. I mean, if you are playing cricket, you have to continue. You can't keep on starting, So I think that's a very important lesson, which I think, but also the other lesson is the issue of in the ANC, we made sure the whole country understand we believe in the primary healthcare approach so that we don't we push a lot on the primary healthcare services, prevention, blah, 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 and not spend a lot on the tertiary. I know most of you guys are specialists. You're not going to like this thought, but that's the cost, that's the economic thing which shows in health economics that's the case. That's all I wanted. I just wanted to add those few things. Okay.
I think you already mentioned about it, Shiva, but Shivam Natarajan has just brought back. Is the infrastructure ready for the NIH bill as it's entirely data dependent?
Oh.
You need to unmute yourself, Shiva.
Yeah.
Okay.
Our infrastructure is actually quite good. What happened is that we did quite a lot of infrastructure build, and we built a lot of services. Tabos built a lot of services in the rural area and all, but it's all uncoordinated and patchy. You don't have a plan that is comprehensively addressing everything. You address this here and you address that there, and you don't have a comprehensive plan. So that's the issue that we are facing at the present moment in how do we bring it together such that all of us are on the same page and we are moving together.
Please unmute yourself, Dr. Tabu.
Just to add, I think there's a fundamental lesson in health. People in health economics always say this. It is very easy to build infrastructure, to build a hospital. But as long as we don't correct the finances, what has happened is that we built some of the hospitals, they look nice, but then because there was no money to run recurrent expenditure, the public hospitals, now they are going one way because you don't maintain, you don't have staff. So the quality of service then becomes a problem. So it's a very important concept. We can cry all we can, but as long as we don't sort out the financing model, it's not going to work.
Venkatesh, Dr. Venkatesh, you had your hand up. You wanted to say something?
Yes, ma'am. Thank you for the opportunity. Sir, it is extremely difficult at the same time to listen to this history. And there are a lot of parallels which we can draw with multiple countries in different continents. But perhaps the case of South Africa was a really heart-wrenching tale. And India has its fair share of bloodshed, and we all know that. But I have two questions for you, sir. Number one, in the pursuit for a common good, in the pursuit for a public good, how do you create allies, especially amongst those who are opposed to you, and especially those who are from our very own profession? That is question number one. And question number two is, public health services is a kind of hand-holding services, which means that until the society achieves a certain degree, a large section of the population achieves a certain degree of aspirational quality to their lives and become independent, how long should the governments be responsible for their healthcare?
You want to take the first one, second one first, Shiva?
Yeah. Can I just answer this in this manner, Yanim? Governments will always and will have to take care of the public for one reason. The private health sector is totally curative in its nature. It is not interested in immunization. It is not interested in water, bringing water and sanitation to the people. It is not interested in electrification. So the determinants of health, the major determinants of health, you'll have to make it into the public sector, because if you don't address the determinants of health, you'll spend a lot of money in curative care, and this is going to be a problem. So it's a simple thing. If you don't do measles vaccination, you're going to get huge amount of measles. Do we want to treat measles? They want to vaccinate people, but the private healthcare won't do that to a big extent, and therefore public health becomes important. And that is why we said, at least as a start, and if just as a matter of interest, our ANC health policy or the national health plan of ours was taken to Thailand, and it was implemented exactly like that by Kurtzen, and today they have 90% universal coverage. But if you don't address primary health care, you're going to have a problem. So at least if you don't, you leave the private sector to manage secondary care and everything, but at least primary health care so that people are taken care of from their primary need and have a referral system to go up. You need to build that system within the state. So to us, we think that in South Africa, where 68% of our people are unemployed, that's our unemployment figure, 68%. Our government is going to be saddled with taking care of the health of the people for a very, very long time. The question about how do you create allies with those who are opposed to the system, we wanted to say leave those who are opposed to the system to oppose it, but let us build our own system that is of excellence. And that is why if you looked at the Taylor Commission report, it said we will upgrade the public services, we will pay people better, we will upgrade the facilities. But unfortunately, we didn't get that 5% windfall. And we didn't manage with what we had because half of it got stolen. So we were not probably worried about making allies of them. We were just worried to build a system where people will come and join in. Eventually, competition would make people choose where they want to go. And that's what we wanted to do. At the present moment, one of the things we did was to say, for doctors to work in the rural areas, you get a 22% rural allowance. Means 22% above your salary you can get if you work in a rural area. So those kind of incentives that we are putting in to say, how do we attract people? But unfortunately, our budget constraint now is so terrible that we can't do this. South Africa is suffering from a huge unemployment where only 16% of the people are contributing in taxes to take care of 84% of the people. We have got indirect tax with VAT, but if you talk about it from that way, we don't have enough employed people to take care of everybody. So they're indigent people and you have to take care of them. And it's not their fault. They were made like that by the previous apartheid government. I hope that answers that.
Shivam, you have
Yes. Thank you, sir. Thank you.
Yeah, thank you, Vidya and Dr. Siva. Awesome, and the passion is palpable. All I just wanted to say is I think many more doctors need to be more interested in going just out of just clinical field into other areas. Otherwise, we are not going to change this health system being pure clinicians. But as clinicians, we definitely do the best of service. There's no doubt about it. But people like Siva, you have done both, and that's what is critical. Where when you go out and you look at it from a system perspective, it makes a huge difference. So hats off to you, and just wanted to say how proud we are of you.
No, thanks very much.
Just to
my favorite
lighten
topic
up.
there was PSM, but I didn't get a chance to do it properly.
So just to lighten
when we did PSM, we never paid attention to it.
Yeah, and it's coming back to bite all of us. So I just wanted to Dr. Girjadev Sharma is one of the patrons of Learning Dental Surgery, and he has many nice stories. So I thought I'll just change the mood. So he wanted to talk about his Professor F.C. Eggleston, who retired at 68 in Ludhiana as director of CMC, and then went on to work in South Africa. So apparently he served in an area in South Africa. He selected a school building in a suburb where there was no surgical facility for 100 kilometers. He had a missionary anesthesia consultant. And between them, they trained 8 nurses in regional anesthesia and also for surgeries like hernia, hysterectomy, appendectomy, and all that. Each person was trained for one procedure. So apparently in a hall, there used to be 4 OT tables, and the professor and the trained anesthetist would observe, and the anesthesia and surgery was performed by trained nurses, and each one performing 1 or 2 procedures repeatedly. Then eventually they were doing as many as 50 operations a day, and 5 years like that he did, and apparently he used to go back to US to beg, borrow, steal, and bring money. So to bring comfort to the ailing underprivileged of South Africa. So the project was funded by the Presbyterian Church. So I was wondering if you knew about the story.
Vidya, there are many like that. If you came to the TBVC states, Transkei, Ciskei, Boputsana, and Venda, almost all the hospitals were built by missionaries. So we had missionary hospitals, and they did amazing work. Just like Arvind, we have a person called Fred Hollis. I don't know if you know him. He actually stole money from Australia, government money. He said, "You people, you'll decimated the indigenous population. I'm going to steal your money." He took the money and came to Africa and other places and did ophthalmology services, provided services for the blind and things like that. He actually stole the money, and he was a wanted person in Australia, and South Africa refused to do. So there were many people like that. Let me just tell you something about how we work. When I came to work, this is a little bit personal now. When we came back to South Africa, there was discrimination. They didn't want us because we were like feared, because we had seen freedom. We knew what was freedom. We'd seen other, so they didn't want us to work in South Africa per se. So what they did is that they said, all foreign doctors, you have to write an exam, HPCSA exam. And if you pass the exams, then you can work in South Africa. But till you pass the exams, you have to work in the TBVC states, Transkei, Ciskei, Bophuthatswana, and Venda, and the homelands. But there, if you fail the exam the second time, you can't work as a doctor. So we had all these people from South Africa who went abroad and studied, and they were working in the TBVC states, and they wrote the exam for the first time. And then they were slave labor because they were scared to write the second time, because if they wrote and failed the second time, they were not able to work as doctors again. I was lucky. I came back into South Africa and I just landed up by chance at Ciskei, and it was December time and there was no doctors, and there were 3 doctors from India. Now, those days, the Ciskei and the Transkei were so-called independent countries. So they imported doctors. So I had Dr. Ram, Dr. Vali, and Dr. Venkat. And 2 of them were leaving, and they said, "You came from Jutma." No, you can work here. And they said to me to work there. On my 3rd day that I was working there, I went to a clinic. And there, this lady was gravid 6, and she's got a Bandl's ring. And I told them, "Take this patient to the hospital now, otherwise she's going to rupture." And she just happened to be the Director General of Ciskei's sister. And just as I was in the clinic is about 18 kilometers away, but it's on a dirt road. She ruptured. The sister came and called me and said, "The patient is white." And I just came there and I looked at it. I gave local anesthetic. I took out the baby. Baby was fine. I sutured a little bit, whatever I could, because it was a clinic. We didn't have much stuff. I packed the abdomen. I put the patient into a car, and I came to Utne. I came to Pedi Hospital. And then in Pedi Hospital, we did everything. She and the baby were fine. The Director General came the next day and said, "Listen, Shiva, you are a South African, you are a Ciskei citizen. Don't bother about anything. You are a Ciskei citizen." And he gave me full registration in Ciskei. Now, when I got full registration in Ciskei, I was lucky. I was able to go and study in South Africa, and I wrote the MFGP. When I wrote the MFGP exam, I was a Dutch student. Then I went and wrote the HPCSA exam, and I was declared failed. Then I took the HPCSA to court, and I said, "How can I fail an exam when I'm your Dutch student on the other side in a postgraduate exam, and I want my paper marked?" And the court, we had a judge, Judge Goldstone at that time, he said, "No, you must mark Dr. Pillay's paper." And they panicked, because if they marked the paper, I would have passed. And there were hundreds of people. So they came and negotiated and asked me. That's how I could have then said, take it for myself, but then I said, okay, then recognize all the doctors that qualified abroad. And then to prevent a suit, they decided to recognize, and that's how I formed Omega, Overseas Medical Graduates Association, and formed. Now, when I worked in Pedi Hospital, it was like what you are talking about. If I had to do a cesarean section, I did the spinal, and the nurse was the anesthetist. The nurse was the pediatrician after I took out the baby, and a nurse was assisting me. Only one doctor did a cesarean section. After time, it was like that. That's what I'm saying. When I was in Pedi, half my nurses, sisters were as good as doctors, because they became so good because of being left alone to manage, and they became good. That's why the first thing I did when I became superintendent Pedi I said, sisters, you can't really work like this as staff nurse. They were actually staff nurses, not even sisters. Go and pass this metric exam. They said, Dr. Pillay, I can't go write exam now. My child is writing metric. How can I go and write metric? So I went to Kubusana school there, and I went to the other school in Pedi, and I said, let these mothers write metric exam. And we had open book exam. And I talked to the principal, and we had open book exam, made them pass metric so that they can become professional nurses. But in the rural hospitals, that's how it was. That's why I'm saying to you, in the rural hospitals, I even did thoracotomies because the person came with a stab heart. There was nobody else. You had to do it. I actually had to put to open a chest, put my finger on a heart that was beating to stop the bleeding. I tried putting sutures, it didn't work, and I had to put my finger like that and drive the person from there to Cecilia Makiwane. But that's how we work, because in these areas it was rural hospitals and we work. So what you're talking about, stories like that, we have hundreds of them in South Africa, and we have had many people who did miraculous work here as mission doctors, and they worked marvelously serving indigent patients. We had Dr. Peter Swift. His whole life he dedicated to going to different hospitals. He was head of Department of Medicine. He had FRCP from 3 London colleges, but he spent every day in the different district hospitals, and he used to have a teaching program, and he used to teach us, and he used to make sure that we did. We have people like Dave Power. So we have had many people like that who during the apartheid days decided that they are not going to go serve the white privileged people. They're going to come and serve black people. Tabos will tell you from his area where he stayed, there was Forte University, and it all started off by missionary people who did this. Thanks.
So, Shiva, we have Ajay Bhandari, yet another football mate of yours. He, on my special request, he logged in. Ajay, is still there? He was walking with his camera on, I think. Ajay, whenever you are ready, we are ready for you. Maybe we just have some time to look at the chat box, and Dr. Venkatesh has put, this is a common sense. The state takes care of people. A nation is not the land, but its people. But world over, profits and profiteers drive power and policies. Capitalism and markets don't have moral limits. The climate is destroying everything. And if you even espouse such ideas, you'll be called a coward.
Can I just tell you something? It's become immoral now. If you look at it's really too immoral. If you look at, that's why that one person said, when COVID came, they said, listen, you're paying billions to Lionel Messi. Why didn't you go ask Lionel Messi to make the COVID vaccine? Because you're paying us peanuts in the virology lab. Now, yesterday I was reading the newspaper video, and this is crazy. Naspers, I think you know Naspers. It's a company on the stock exchange international.
Yeah. If just for a brief moment, Ajay, were you trying to say something?
No, it's so good to see Siva Pillay and Ranjit there. That's it. Sorry, I got in late. I mean, I have been campaigning somewhere, so my apologies. But wonderful to see Shiva as usual and Ranjit. That's about it. I mean,
Ajay, show us your face, man.
I will definitely show you my face. It's got old, but it's okay.
You got all your hair on the head, man. Still, you're looking good,
wonderful
man.
Wonderful seeing you, Shiva.
Wow, no, you're looking good.
Really good to see you guys.
Man. That's really nice.
Yeah. And also Ranjit. I mean, really, it's such a wonderful thing to have. Thank you so much, and thank you, Vidya, for reminding me.
So sorry for interrupting you, Shiva. Please go ahead.
No. So I was just saying now. So Naspers, day before yesterday, said to its CEO, we will give you $100 million. $100 million if you reach certain targets as a bonus. Now, how is that guy going to reach that target? He's going to decrease salaries. He's going to retrench people. He's going to work with skeleton staff. He's going to start this thing, mechanizing and putting mechanisms in place for machines to replace human beings. And that's how he's going to get. Now you ask yourself, who has made Naspers where it is today? So millions of people who are working. But you're going to pay $100 million to one person to make it work, what is he going to do? He's going to exploit people. And this kind of thinking, I really do not understand it anymore, where we've gone mad in greed. How can a man even spend $100 million, Vidya? So there's a craziness that is going on, and that craziness has come into South Africa also, by the way. It's not how much you can eat, it's that I must eat as much as I can. And we look at all of us who were activists before, we were earning enough. And that's why I was asking Tabo, one of my friends who is a deputy, I won't mention his name, but he was the Deputy Director General of Health. You're getting a package which is about 1.4 million, 1.5 million rands. Why the hell do you need to get a bribe? Why do you have to do something corrupt? But this greed has become just unbelievable, and it's uncontrolled now, and we don't know what we are doing anymore. And with the event of social media and instant gratification now, it's gone mad. I just want to.
Dr. Venkatesh, did you have your hand up first? You want to say something?
Yes, ma'am. Sorry, since there are no further questions, I thought I'll ask one more. Sir, in your presentation, you said when the pushback for the program from the private sector was very high at some point of time when the idea was conceived in 2005 for an NHI. You said that one of the things that was done was to create awareness among the public, to go to the people, mobilize support. That was, if I rightly remember, one of the slides said that. I'm part of a small group of doctors, what we call as Doctors Association for Social Equality here in Tamil Nadu, where we try to back for basic healthcare needs for certain segments of population that are ostracized and colonized, and some of them are ghettoized. What we find is it's extremely difficult to create awareness about how policies affect people. How did you go about doing this in South Africa, and what's the response of the public? Did people, the common working class, were able to understand what is in store for them, how these policies actually affect them, how the new ideas which are received in terms of public good really help them? How did you do it, and what were your experiences, sir?
You see, Narajan, at the present moment in South Africa, when we talk social health insurance, because 80%, 85% of the people are dependent on the state, we have 100% support for national health insurance. The unions back it 100%. The public back it 100%. That is why the ANC as a ploy started when they lose power, they put this NHI bill, hoping that if we're saying we're going to pass NHI bill, people will vote for them now. But what they put into the bill is not NHI. So we have got 100% support. But let me tell you about pushback and what pushback can do. So when Dr.Siva there was given the job to revitalize public hospitals. So they started systematically to improve hospitals, improve the equipment, improve the services and everything. The private hospitals suddenly realized they are usually in a huge crisis. Their livelihoods are going to be threatened. They took 15% of their budget and went on a massive campaign to talk about Swat Kafar. Swat Kafar is about black fear, fear of black people. You'll be treated by black people. You'll have a black doctor treating you, this. So that's the first one they started with. When Swat Kafar didn't work enough, they went on into started publishing atrocities. They started to pay people to say, if anything happened to you in the public sector, come and tell us and we're going to publish it for you. And we're going to start suing the government. So they started to make a public fund to sue government. And that's how we got all these medical legal challenges against us for negligence and this and that. But if you went there, every day in the newspaper on the second page will be something about some public hospitals, such that if you go to people in my town now in Port Elizabeth and say, let's go to Dora Ginsa Hospital and say, yo, doctor, I don't want to go to Dora, I don't want to die. Because it's associated with death. That's what the campaign did. Yet if you go to Daragin's hospital, Tabo will tell you we built 4 new wings. It is improved fantastically. We've got 13 consultants there, but it makes no difference now because the perception has gone. And so when you're fighting against capital like that, it's very, very difficult. And then the second part of it is that when we started, we had activists who it was in the interest, like in my time, if I was a leader or something, I'll go to people and have public meetings and talk. Now the new politician is not interested in this. He's interested in who's giving him a kickback. And so he is not going to, and that is why the current crop of politicians have no credibility and cannot get public support. Whereas in our time, if Mandela went somewhere and he said, let's do this, there was enormous support. That is why during the pandemic that came about for COVID, the premier recognized he would not be able to do anything on us. He called all of us who were old people like before, and we came back and we went to VW and all. They helped us to set up a field hospital and everything because we had credibility. We had people genuinely knew that if they gave money to us, it will not be stolen. They cannot say that for anybody else. So in the end, we got used again when the pandemic came. Now that the pandemic is gone, we are thrown away again. It's a bad story, but we have to just continue like that.
Dr.
The
Tabo,
experience is
you have
everywhere the
something?
same, I guess.
Dr. Tabo, would you like to add something?
Things, just 2 things to add, just as a lesson. One of the areas which is problematic is health technology. We tried to regulate it, but until I left the national department, we are not succeeding, because what happens, the private sector buys these crazy health technologies, and then because they don't utilize them, they sack patients and then they do unnecessary things. And internationally it's known that health technology has to be regulated. The other thing we tried to do, I think Shiva forgot to talk about it, and we're taken all over the place to court. We thought that we were going to have a certificate of need for you to establish a health facility, so that by certificate of need, we drag people to where there's a need and stop you having a hospital next to another hospital, having a private practice next door to another private practice. But again, it failed because of this pushback and taking to court. And it's something, especially the health technology part, is something which drives the health expenditure quite high.
Thank you. Radhakrishna, I'd like to say something. If anyone else has anything to say, please put up your hand. Otherwise, we are already, 15 minutes over the time. So over to you, Radhakrishna.
When I was in Kathmandu many years ago, I had fever, headache, and I went to buy paracetamol. That fellow didn't give me. He said, you need a prescription. I mean, I don't know. I was surprised. And then I understood that it's not easy to procure medicine. I don't know whether the situation is the same now, but it's very heartening to hear from Ranjit that public hospitals are as good as private hospitals, and they still maintain that standard. I saw a similar thing in Sri Lanka. Sri Lanka also, you can't get, I worked there for 3 years, and you can't get any medication without a prescription. You need a definite prescription. Not just that, you don't get this combination drugs of paracetamol and histamine combination. That there's not, I don't know whether that exists in Nepal is still maintaining standard, and so is Sri Lanka. But, as far as Siva is concerned, I remember Siva is, happy-go-lucky chap, always celebrating and on the football field. I never, ever imagined that he'll become one such famous doctor who was specialized in so many subjects, and more than that in medical administration. When I had wanted to make a poster, I wanted to get a good picture of Siva, and I Googled, I found a lot of South African newspapers painted him as a hero. And that he was a very ruthless person when he is sort of eradicated corruption, and he sort of chucked out people left, right, center in the thousands. And I was surprised that he was so powerful. But then again, he had soon opposition caught up with you and you had to quit your post. I always thought South Africa is not Africa. It's different from Africa. And, that's where the huge, very famous hospital is there. And that's where the cardiac transplant happened. A cardiac transplant can't happen in Uganda or Ethiopia. It happened in South Africa. I thought it was very different. But after hearing your story, Siva, I think we're back to square one. Whatever the medical situation during apartheid, it looks like it's come back now. And again, I think your rulers are as corrupt and as greedy as the other African rulers. It's very, very sad to hear that. In spite of all your efforts. Now, India is not far behind. India was good in the public sector years ago. Now, private sector has taken over. Excepting for a few central institutions, most of our governmental institutions are very derelict. They don't have the best of teachers, although they have the best of students, and the quality of treatment has come down. If you see any good doctor, any good medical teacher is in the private sector, not public sector. Again, most private sector hospitals are owned by corrupt politicians in India who use their black money to, run these hospitals. It's pretty sad. You have such a formula to control the private sector. I think Indian government has to take your services to set the private sector right. Vidya and me work in a private sector, but we silently work because we have no other option. But that is the situation here, Siva. I think India is not very different from what is there in South Africa.
So, Amit Ghosh is here. Amit, would you like to say something?
Yeah, I mean, what can I say after what I heard? First of all, congratulations to Shiva and Ranjit. It's not very unusual for me to think where they are and why they are doing what they are doing. These were leadership qualities that I had seen in both of them when they were in JIPMER. They were in the forefront of any kind of social, whenever anything which went out of the social norms, they would speak out and they would be there. And I think being in a football field was one way of getting rid of the aggression which they had. And they would show it in the fields and be very passionate about him. And we would all shrink to meet them if they lost a game because they'll be both in the foulest of moods at that time. I think that has stuck on. I would say every nation is growing. The people are learning. These are parts of I wouldn't say mistakes. This is part of growing up. Corruption comes because, number one, there are two types of people. One, we don't pay them enough, or we pay them, but they are still hungry and we don't pay others. So there is this disparity of economic wealth, which until unless that is shared, the basic salary doesn't come up. If that does not come up and people keep it low, I think these kind of situations will always persist. But having said that, the quest of individuals who put their life at peril, like Nelson Mandela, and I'm sure Shiva and everybody else, in the quest of doing things in the best way they can, and also putting them in peril that their families might suffer from the consequences of their what they think is normal activity, what others would say paranormal activity, is really commendable. But it is the small steps that we take. I've lived long enough to see that there's no one way, there's no good way. But there's one thing which everybody I see everywhere, whichever country, regardless what you earn, everybody asks one question: what is in for me? Having said that, I heard all the thing about the common norm and people should be doing the common good and things like that. Without collective bargaining, without having an organization or a country which thinks that each life is valuable, not if you're black and white. And looks like in South Africa, there are many shades of black and many shades of white, and all of them are saying I'm up and I'm down. So this kind of stuff I've seen in India. Every state has it. Within the state, there are different languages. They have it. So, but everybody's trying to live and do the best we can. So I think being professionals, the best we can do is understand the system. There's no perfect system, and within the system working where it is. I mean, I'm working in the Mayo Clinic for the last 25 years. Even here, we have a system. and we have to work with the system based on every 8 years, whoever comes. So having said that, I think the best thing is to stay alive, keep breathing. Ajay is doing that in his part in politics, and each of us are doing that. We are highly qualified people. Staying in the business of service and working for people in whichever way we can is probably the best thing which we can do. If we lose our heads and end up in a prison or end up losing our life, that's probably not the best way to do our service, because the world will go on with us, better with us, but it'll also go on without us. So I think be safe whatever you're doing, and be passionate. And hats off to what you're doing. I wouldn't be able to diagnose Bandel's ring or something right now, which you have done that. I wouldn't be able to put my finger and stop a bleeding heart. Maybe by words I can, but not else. But I also appreciate the sessions I sit. I sit to the very end. Want to hear Patta's, what I call Patta's rant. And he dices and slices. There is nobody who is safe from him. No system which is safe. No organization which is safe. But I never saw this quality in him, or maybe I didn't see that. He was always a kind-hearted, smiley guy. But this man has changed. He's evolved. He's like a firebrand. And so is his partner, Vidya, who's quietly, I think, stimulates him to make him make all the comment. And Vidya says all those things without saying anything. And all the hard work and the tough words are spoken by Patta. But I really appreciate what you guys have become. It's been a real honor, as one of the pride of my life, to have studied at JIPMER and to have actually rubbed shoulders with friends like you. We never realized that in the heat of the moment, when it was so hot outside and we were sweating through a PSM lecture or sleeping through it, that one day we'll be all still benefiting from the lessons we learned and be able to serve the way we are. So keep waving the flag high, keep doing what you're doing. And I'm sure with your spirit, you are going to do great work. And there is not going to be any force which stops you or snuffs you, but be smart, because we need your smartness. We can't have Patta, who's one of the India's best gastrosurgeon, just becoming a firebrand, putting a thing around his head, and go all out in the street and fighting. We need you doing the surgery you do. We need Vidya doing the anesthesia. We need Siva doing what he does, and Ajay, and of course Ranjit, my friend, is doing what he's doing. So it doesn't matter where we are in the world. I think we have had great roots, and hats off to you. Hats off to you guys for what you're doing. But let me say that I'm doing the same as you guys are doing. I'm not a very quiet person, as you see, but I've learned enough to say that you got to be in the game. You got to be in the field. You cannot be in the sidelines. If you do too much, they'll put you in the sideline. They'll put you in the chain. You cannot be a Ronaldo or a Messi or something from the sidelines. You have to be in the field. So you have to give, you have to take. That's how your country will progress. You cannot be a nihilist and say it cannot be done. My country is all bullshit and this and that. You are your country. You are what it is and what you make of it. So I think this is not very much medicine, but everyone who has done medicine or been a part of medicine, we all become politics, medicine, culture. We find ourselves much more than what we learned in the classrooms. And this is what life is, and we find ourselves there, and all of us are leaders, and you are a leader. And Shiva, what you have done and what you're doing is, I think your path kind of switched very soon after you left JIPMER, and we started hearing stories, even 5 years, 10 years. Most of us had to wait for 10, 15, 20 years to make our impact, but your impact was immediate. So that speaks volumes of you, and keep doing what you're doing, my friend.
So as a continuation of what you said, Amit, Venkatesh has written, medicine is a social science and politics is medicine writ large. And it was said long ago by Wako. So we are just, rediscovering old things again. So we really out of time. So Shiva, your closing comments.
No, it was really nice to talk to all of you all again, to see all the faces and to look at everybody. You know, I always say to my wife and everybody, in JIPMER, I was like scraping the bottom of the barrel, just suffering to pass. So all my classmates and college mates, they're all big shots. They're really professors and head of departments and this and that. I'm just going through the motions here and trying to make a change. But I think JIPMA was a fantastic learning ground for all of us. And it was really nice for us to learn there, because we learned more than medicine. Let us be honest. And the advantage that we had is that we had people from all over India coming there, different cultures, and it was a cosmopolitan place where we grew as people. And I think if you look at what it is, where we are now, we're very proud of what it is. It was really an honor, Vidya, for me to present here today, and I must thank you for that. I still believe that universal health coverage is a goal that can be achieved. It can be done, and I think I think we will keep fighting for it today.
Over to you, Ranjit. Your closing comments. You're muted, Ranjit. You're muted.
Mute. Yeah. Okay. Yeah.
Yeah.
Thank you so much. Thank you so much tonight for this extraordinary session where, I got to see even Amit and our goalkeeper. And it was a lifetime experience after all these years. Pleasure seeing Siva doing all that wonderful work. And all of us have been doing great work. And let's keep in touch, because we're all not getting younger anymore. Good night. Thank you.
So we'll meet again next week, but it will be a different thing. It will be a Beyond Medicine session, and I'll leave it as a surprise for you. So you'll know by Wednesday what the next episode is going to be. Till then, take care and stay safe. Good night.